Welcome, everyone. We'll give everyone just a quick moment to sign in, and then we'll get things started. Okay, welcome, and thank you for joining us this afternoon for Northwestern's Robert J. Havey, MD, Institute for Global Health webinar, Small Patients, Global Impact, inside Northwestern Center for Global Pediatric Health. My name is Jen Burke, and I'm a member of Feinberg's Development and Alumni Relations team for the Havey Institute for Global Health. Today's event will begin with a welcome from Dr. Robert J. Havey, followed by a presentation from Drs. Colleen Fant and Sarah Fargo, with a moderated discussion afterwards. Now I'm pleased to introduce Dr. Robert J. Havey. Dr. Robert Havey is the Deputy Director of the Havey Institute for Global Health, founder of the Global Health Initiative Fund, and Clinical Professor of Medicine at the Feinberg School of Medicine. Dr. Havey is an internal medicine physician at Northwestern, where he is currently Vice President of Primary Care Operations for Northwestern Medical Group and the Chief Medical Officer of Northwestern's new medical group in Naples, Florida. He is a tireless advocate for global health and for the importance of primary care in all health systems. Northwestern University Feinberg School of Medicine's Havey Institute for Global Health has a mission to expand knowledge and build capacity in global health through transdisciplinary research and education partnerships. Thank you, Dr. Havey.
Yeah, thank you, Jen, and welcome everyone to this webinar. Pretty excited to have this today, and I think everyone will really find it interesting. You can't think about global health without thinking about children and the difficulty with children in our low resource, low and middle income countries in accessing any healthcare, and certainly good healthcare. Everybody has heard stories about childhood mortality, about all sorts of shortages in care, food and water and vaccinations. And I think you'll enjoy hearing about the efforts of our incredible pediatric docs who have just officially joined us in the Institute as one of our centers, but have been doing this work for years. The webinar will be presented by our co-directors of the Pediatric Center, which are two really talented and very committed pediatricians. First, in no particular order, is Dr. Colleen Fant. She's an attending physician in emergency medicine at Lurie Children's. She graduated from Northwestern University with a minor in global health. And she spent a year in Ghana with a nonprofit organization before going on to Tufts University of Medical School. She went from Tufts over to Mass General Hospital for Children and did her residency there, and then did a full fellowship in emergency pediatric medicine at Lurie Children's. Dr. Fant has worked in the Department of Pediatrics here at Lurie Children's, co-leading programming and global health, and she served in leadership roles with the Global Health Institute Center for Global Health Education. She's been amazing and really instrumental in growing a partnership between Lurie's and Bugando Medical Center in Tanzania, as well as with Maseno University in Kenya. Her current work really focuses on increasing accessibility of simulation-based medical education in these low resource areas, as well as partnership-focused projects in ultrasound, teaching that to a lot of our partner sites, pediatric trauma, and pediatric cardiology programming. Her co-lead and partner in the Global Health Center for Pediatrics here is Dr. Sarah Fargo. She's an attending physician in infectious disease at Lurie Children's. She obtained her medical degree at the University of New England and completed a pediatric residency at Phoenix Children's Hospital. She spent a year working as a pediatric AIDS core physician for the Baylor International Pediatric AIDS Initiative in Malawi. And she's also trained in infectious disease at Children's National Medical Center in Washington, D.C. Her research has really focused on the complications of HIV. We don't think a lot in the States lately about HIV because we kind of think it's a non-entity. It is not a non-disease. There's new cases every day. And the low and middle income world is still decimated by this. And children are still born with this every day. So work by people like Dr. Fargo is critically needed in these areas where children are just afflicted with this terrible virus. and really have to be managed so that they can grow up. And even as they do grow, they are still faced with a lot of problems from chronic HIV, from the medications and so forth. Dr. Fargo is the principal investigator on multiple NIH-funded studies in the US and in Africa to better understand the long-term health outcomes of people who have HIV as children and grow into adulthood. She specializes in providing HIV care and treatments to infants, children, and adolescents living with and exposed to HIV, as well as all other aspects of infectious disease problems that impact children. So thanks for joining us today, Colleen and Sarah. We're looking forward to hearing your talk, and I'll turn it over to you.
Thank you for the kind introduction.
Great. Thank you.
All right, perfect. So good morning, everyone. Thank you for joining us today. We'll start this presentation by giving you a little bit of the history of the center. So prior to the center's founding, which was just last year in 2025, Lurie and Northwestern both had global pediatric activities that actually happened in silos with some duplicative efforts. There was really no centralized knowledge base and way for us to collaborate and share our efforts and knowledge and projects. There was really limited knowledge of what each other was doing, and there was also no structured mentoring for our students and staff. Since the launching of our center last year, we now have established pillars, which I'll talk about in the next slide. And this has really allowed us to come together as faculty to really be more less duplicative and more collaborative. This has also really helped our students, residents, and fellows have structured efforts in terms of their education and experiences. So the center's mission is really quite straightforward. Our goal is to advance child health globally through research, education, and equitable partnerships. And Colleen will talk about what that equity means, but for us, that really also translates into making sure that all of our projects and programs have some bi-directionality, and that can cause a boomerang effect. And what I mean by that is everybody benefits. Both the investigators here in the US, our trainees, our residents, our medical students, and also our collaborators in international countries, mainly in Africa, sub-Saharan Africa. So we want to ensure that we continue our work in creating some equity. So the center is organized in 3 pillars that are highlighted here. The first one that I'll talk about that is near and dear to my heart is, as you heard it, I'm a physician scientist. I wear the research hat in this center. Our goal is really to ensure, as I mentioned, that we continue to mentor our early career researchers and really grab them at all level of training. So everything from undergraduate to medical students to further on in their pediatric subspecialty training. My focus is pediatric HIV research, so obviously I'm a little bit biased, and I'll talk about that later on in this talk. But we want to ensure that we can pair up investigators and collaborators who are interested no matter what the topic is. And fortunately, our Rolodex has become quite large in terms of who we know and how we can connect people. We want to make sure we launch new studies with established partners and grow our research portfolio. In terms of education, which Colleen will talk to you a little bit about, we want to ensure that we have global health experiences, both for our students here locally, but also internationally. We host international partners, which you'll hear about, is also a long-term standing program and very successful. Unfortunately, on pause for this year, but it's been really beneficial to both our Lurie residents and our Tanzanian partners. We offer pre-departure training. We'll tell you a little bit about this as well. Sometimes it's not the interest, it's trying to understand the logistics of how to gain global health experience. And then we create educational opportunities with our partner communities and collaborators. In terms of advocacy, we're really hoping to to focus the center and be a framework to train sessions on global pediatric advocacy. Tomorrow, we actually are hosting a webinar working with the United Nations to increase our advocacy footprint. And then at Lurie, we're collaborating with the pediatric refugee and immigrant programs. So next, Colleen is going to tell you about what we mean by global health.
Yeah, thanks, Sarah. So hopefully this will become kind of clear as we talk through the different activities a little bit more, but we try to guide everything we do with these kind of five really just like benchmarking principles. So we really think it's important for global health to be longitudinal. So all of the relationships we have are years, if not decades old, and we really try to commit to a partner and stick with it rather than kind of just constantly get new different partners going. And that really allows us to focus on community identified needs rather than kind of one-off activities. We really emphasize work that's sustainable. By that, I mean, that's very much a buzzword, but for us, that really means that we want to focus on policies and projects that are ongoing, responsible, and with the ultimate goal of each of them being self-sufficient. Capacity building is huge, which is why it's in the center here. We come from Lurie Children's in Northwestern, where we have access to all of these incredible educators and researchers and clinicians that take wonderful care of children and families in the Chicagoland area. And we really want to try our hardest to use that expertise and help build capacity of our peers around the world taking care of children and families. We try to take an anti-colonial approach as much as we can. And by that, I mean that we really want to decentralize ourselves and our particular interests from all the work we do and really make the focus of all of the work to be partner-centric, meaning we're not setting the priorities, our partners are setting the priorities. And then bidirectional. So kind of to Sarah's earlier point, the idea that anything we do, we really try to make it as mutually beneficial and respectful for all of our different partner sites, to try to emphasize like an equitable relationship and mitigate power differentials as much as we can. So we have a lot of really cool partner sites, most of which are in Eastern and Southern Africa. We have partners in Uganda, Makerere University, and the Joint Clinical Research Center. We have partners in Cape Town, South Africa. We have partners in Tanzania, both in Mwanza, Tanzania, Bugando Medical Center, Muhimbili National Hospital in Dar es Salaam, and then a partner site in Kisumu, Kenya, which is Maseno University. So we do lots of cool different things around education. And this is just kind of three of them I want to highlight for you guys today. We're going to talk about kind of where my heart and my joy lies, which is in pediatric simulation, talk about our pediatric cardiology care program, and I want to just highlight our training programs. So one of the main activities we do as a center is we work within simulation-based education to improve pediatric care. So this program started in 2020 as a small pilot that was donor grant funded, which we wanted to train Kenyan pediatricians to use simulated like mannequins in a simulated lab to teach their students how to care for pediatric patients. So this is some images from our first iteration of the training. You can see we're all wearing masks. It's in 2021, 2020. But the idea being pediatricians were able to practice on these mannequins, high-risk procedures, high-risk scenarios, so that they were better informed and more trained when they were working with children. So what is simulation? I take this for granted, but it's this really cool educational tool. It's used not only in medicine, but in many different high-risk fields, such as business. People know a lot about it from like airline safety, where you train people on procedures and scenarios in like a safe simulated environment that's both safe for the learner to make mistakes, safe for patients, that they're not experiencing those mistakes, so that when they then encounter these experiences in clinical care, they're better trained, do a better job, and there's better patient outcomes. So it's just really critical for pediatric patients, because a lot of pediatric illness is quick and it's not as common as adult illness. So it's more rare. It's often more acute. And by using simulation, you're able to train lots of different learners and how to take care of an illness that they may see 1-2 times in their life. These are both pictures from a most recent simulation training program we had in Mwanza, Tanzania, where we were doing trainings around infant resuscitation or kind of around delivery, and then another one around pediatric trauma. So we work with the Lurie Children's Simulation Program. It's called KidStar. So simulation is ubiquitous in pretty much all Western medical education centers. Lurie Children's is also incredibly well known for its simulation expertise. At Simulation, at Lurie Children's, their program KidStar basically hosts these simulated scenarios for medical students, residents, fellows, faculty, community sites to help people take better care of children. And we partnered with KidStar to do this work in other countries. So now we've done these trainings where we train faculty in how to use simulation for their own learners in Tanzania, Kenya, Rwanda, Saudi Arabia. And we recruit different educators from across Lurie, nursing educators, physician educators, transport team educators to basically do this training. One of the coolest things about using simulation as our kind of global health tool is we're not really just focused on teaching individual scenarios or skills. We're really talking about teaching a educational tool. So the effects of it are exponentially larger. So by teaching educators a new way to teach that has better outcomes, what we're doing is actually impacting their students who then learn to take better care of patients and also learn this teaching methodology that they could do in the future, with the idea being that it really just grows and grows over time. We built a low technology simulation center in Mwanza, Tanzania with donor funds where they have all these different mannequins of different ages and sizes that they're able to use in their clinical space to run very quick scenarios to help their learners be better at intubation, be better at managing heart disease, be better at managing sepsis and trauma, and kind of practice these skills as often as they can. In our most recent training, we trained 5 pediatricians and 6 nursing educators to use this teaching method to improve their learners' care. So at the same site, we also have a pretty interesting partnership around heart disease in Tanzania. So this is a kind of a referral hospital. So that means that it's not the top hospital in the country. So often if kids have very, very severe disease, they have to be referred out, but it's kind of that mid-level. So they are still getting kids referred in. So at this hospital, lots and lots of kids were coming in with pediatric heart disease, either heart disease they were born with or that they acquired in the first couple of years of life. And at this hospital, there was only a handful of pediatricians, and only one of which who could do the heart ultrasounds that were needed to diagnose illness and start care. In 2023, they hired their first pediatric cardiologist or specialist in pediatric heart disease. So we worked very closely with her, Dr. Juliet Cavarighi, to start an echocardiogram training program. So what that means is every year we spend about a week in Mwanza, Tanzania with our cardiologist from Lurie, and we train not only all the pediatric faculty there, but all the pediatric residents in how to do these heart ultrasounds to diagnose and treat pediatric heart disease. So since this has happened, over probably 100 pediatricians have now been trained in doing echocardiograms or heart ultrasounds to diagnose and treat children with heart disease that hadn't had that skill before. And the most important part of this training is not that they're replacing pediatric cardiologists, but that they're recognizing kids who need advanced care and appropriately referring them to wherever that might happen. So this partnership, which is, again, this is now the 3rd year, has really significantly increased the ability for children and families in this part of Tanzania to get diagnosis for pediatric heart disease and get that accurate, timely treatment. So the last piece of the education program I want to talk about is just our trainee programs. So this has actually been probably the longest standing part of global health at Lurie Children's. We think that observerships are hugely important to people learning to take care of children and families. And by that, I mean actually observing what clinical care looks like in multiple parts of the world, which allows learners to really understand what care of children looks like in differently resource settings. So since 2007, our pediatric residents at Lurie's And the pediatric residents from Bugando Medical Center in Mwanza, Tanzania, have had this bidirectional relationship where their residents come to Lurie for a month, our residents have the opportunity to go to Tanzania for a month and really kind of observe the different types of care that happen on the wards, better understand what pediatric diseases look like, and really kind of create this almost like family around, improving the care of children locally. These are just two pictures. The top one is two of our trainees last year who are supporting our pediatric cardiology program. And then the bottom picture is the Tanzanian residents and faculty who were visiting Chicago last spring, which was very cold. So let's turn back over to Sarah to talk a little bit about pediatric research.
All right, thank you, Colleen. So, I talked about this pediatric research and the boomerang effect. So, as Dr. Havey mentioned, I worked in Malawi as a Baylor Pediatric AIDS Initiative physician, and this was kind of my first week on the ward. So, I just want to show you this picture. This is a colleague of mine. We were rounding together on the malnutrition wards, and we realized that day that there were 12 pediatricians in country. 10 of them had been deployed by Baylor. So the human resource shortage was really kind of our main mission. And as Colleen mentioned, this is really kind of transitioning into why it's so important to scale up education, because what we give back, teachers teaching how to teach can really make a huge impact. So on this malnutrition ward, we quickly realized that a lot of these malnourished children were also co-infected with a variety of diseases. And this being 2009, 2010, as you can imagine, the HIV burden was really sky high. Malawi was not a PEPFAR country yet, so there was not a lot of treatment available. There was even less treatment available to children. So some of the children that you see here were diagnosed with co-infection, tuberculosis, malaria, or HIV. And then we also realized that the main mode of transmission was actually perinatally acquired, so mother transmitting to children. And I worked in a semi-rural setting as the sole practitioner for a while until I could train, officers and nurses to take my spot when I left. But you can see mothers lining up for their care here. And at the time, there was just a single dose of a drug that we would give. And there was we were part of a lot of research protocols in order to try to change guidelines. And so this brings me back to this boomerang effect, is that a lot of the blueprint for what we learned in these settings where the prevalence was really high and the cost of research is actually much lower than doing it at higher income or the global north, was really kind of the blueprint for what ended up happening worldwide for the care of mother-to-child transmission for HIV. So in the US, in the mid-90s, the transmission was around 35%. And from studies that we learned worldwide, it's almost non-existent. It's less than 1%. So again, a lot of the breakthroughs that happened in resource-limited settings really created guidelines and protocols that are now widely used in the United States. I talked about prevention of mother to child. The other thing that happened is early infant diagnosis using dried blood spot was really kind of a breakthrough for lower income settings that are now applicable here, especially in rural area, where all you have to do is kind of do a pinprick of the finger, put that on a little card. It's almost like the newborn screen, right? And you can determine whether the infant is positive or not. And that really was a huge breakthrough at the time. And that technology was developed in lower and middle income settings. And then in terms of chronic disease care models, so Sub-Saharan Africa is at this tipping point where it's actually going to be the continent with the largest number of young people, 13 to 30 years old, whereas the rest of the world is really aging. The continent is actually the one with the largest number of youth. And so what's interesting is there's also at the same time an intersection of infectious disease and chronic non-communicable disease. So it's really a fascinating place, and it's not a monolith, right? It's a continent and the countries are very different. And within the countries, there's lots of different, socioeconomics, genetics, and ethnicities. But it's a fascinating place at which, especially for me, an infectious disease practitioner, I can use some of these disease care models to really focus on chronic disease, which is a funny thing to say for an infectious disease physician. But again, we're kind of at that cross section of communicable and non-communicable disease. And my research in sub-Saharan Africa has helped kind of develop frameworks and models for how to do that here in the US. And so it's really been fascinating. I put a couple pictures here of some of the topics that I'm interested in outside of infectious disease. What we're learning in terms of protecting children from climate-sensitive diseases abroad has, again, really helped us anticipate and respond to threats here in the global north and at home in the US. Global pediatric research environments are really uniquely set up because you have to develop things that are cheaper, cost efficient, scalable, and that's when AI and technology is really being quite a breakthrough. So I mentioned earlier how there were 12 pediatricians in this country, 10 of them were really kind of imported from the US. The same can be true for really higher skilled professions. So I'll give you an example. I have been funded by the Global Health Institute to do a cardiac MRI study, and the radiologist that I'm working with now is really overburdened. And so we're trying to help him develop AI solution to quickly read MRIs and anything. Of course, this is going through, vast QA, QCs, but anything that gets flagged, he can look at more closely. And so we're hoping to really have AI be a cost-efficient solution and for things to be translated to the global north. So innovation under constraints really produce solutions that are more efficient, scalable, and equitable. And that's also what I'm interested as a global health researcher. I'll give you another example of how the Center for Global Pediatric Health really is serving as a platform. So this is an event that's happening tomorrow at the United Nations High-Level Political Forum. For those of you who may not know, the High-Level Political Forum is really focused on policy for sustainable development at the United Nations. This has been spearheaded by our colleague, Arik Shimek, who really was leading the Coalition of Nurses at the United Nations. And what we're hoping to do is use our platform as the center to really invest in people and systems that make hepatitis elimination possible. So we've partnered with Claudia Hawkins, who's an infectious disease attending at Northwestern, Ravi Javeri, who's the head of my division at Lurie Children's, Jabril and Naida, who are both working for the Coalition of Global Hepatitis Elimination at the World Health Organization. So again, we're uniquely positioned to try to accelerate development and making infectious disease elimination possible. I mentioned this earlier. Sometimes the biggest challenge is really not lack of interest, but trying to figure out access and clear pathways for how to get into global health. And that's what Colleen and I are hoping to make things a little bit easier for our colleagues and trainees. So our center is designed and hopefully will be designed to help solve that problem. Will serve as a hub where faculty and trainees can really find mentorship, funding, partnerships, and real opportunities to engage. We can make global health not just possible, but really more navigable, more structured, and more impactful. And you can see different entry points here at which stage we're hoping the center can help. So I'll skip this slide because I think it's a little bit repetitive of what I just said. I want to come back to this kind of boomerang effect for how equity and bi-directional relationships and programs can have an effect. So these are quotes from our Ann and Robert Lurie pediatric residents, and I'll just read them to you. So I have enjoyed having the Tanzanian residents in our conferences throughout residency. They provide great context for medical care globally and push us to think about medicine outside of our urban center bubble. I think that's an incredible opportunity for our residents to have Tanzanian residents with them. Again, the learning and the opportunities really go both ways. I'll read you another quote. Having Tanzanian residents join rounds and introducing them to family shows how we are an internationally connected hospital and medical school that is of high enough caliber that programs in other countries want their doctors to learn from us. I think those are incredible quotes, and I won't say more about that because For lack of a better term, I think they speak for themselves. So lastly, I'll end with the center vision for the future, which is really training leaders, strengthening systems, and transforming child health globally. Just a little bit more about this. Training leaders, I think hopefully we've convinced you that training leaders can really have a tremendous impact. So not only in terms of scaling simulation that Colleen talked about, specialty training globally, and we can have specific stories to tell you about with Dr. Havey later on in the Q&A portion, to strengthen the frontline clinical capacity, which is an incredibly important thing to do, especially at a time of lots of conflicts and war zone and critical shortage. And this will improve outcomes for vulnerable children worldwide. Strengthening systems, I think we've talked about, and transforming child health globally is part of our mission. So I'll end it there, and really want to thank you for your time and attention today.
Fantastic. Thank you, Sarah and Colleen. I think the audience can kind of get a sense of what we're trying to do. If you think about what we do at Northwestern and Global Health, everything we do takes an enormous effort, and all of us do it kind of as a sideline because we have responsibilities here. Nobody gets paid for this. We all do this voluntarily. But we're trying to really make a difference and make an impact, knowing we have an issue with resources, bandwidth, and so forth. And that's why this is pretty exciting if you look at what Sarah and Colleen have done. Think about just a simple word of scale. There are, hundreds of millions of children that need some sort of support to have a chance to live a normal life. And yet we can't individually examine every one of those. Sorry, I guess my video wasn't started. But by using things like simulation, teaching the other teachers so that they can then become experts in their own areas, the future of AI and what that will help us do to scale, that's going to make a big difference. I always tell myself every day, since I touch upon this institute every day, if not for places like us and other organizations around the world that try to provide some partnerships with these low resource centers, if we don't do this, who does this? I mean, who gets involved? I mean, it's hard to get involved with these things, but we've built an infrastructure. We're committed to try to have a stronger and stronger infrastructure, to have stronger and stronger partnerships that make a big difference. Even those pictures of bringing folks from low resource areas over here, this isn't medical tourism. This is teaching the future leaders so they go back to their own populations and are even better resourced to take care of that. So I hope you got a sense of that from this. There are a bunch of questions which I think will be kind of fun to touch upon. The first one that I wanted to ask, that I think the audience would enjoy hearing since they've met Colleen and Sarah, is I'm going to throw this out to both of them. What first drew each of you to Global Pediatric Health, and what's kept you committed to this work? So Sarah, Colleen, one of you can start, the other can finish.
Yeah, I'll just say, as a pediatrician, I had my first experience before even the term global health was coined, right? At the time, it was still international health and very unidirectional. And my first kind of shock/realization is that despite all of my training, a child's determination to thrive and survive is still based on where they're born. And for me, that was really a wake-up call in my first global health experience. And that has kept me going. I think also we have a tendency to look at things through a negative lens, but just in my own training, and I'm not that old, and I always say this, infant mortality has drastically decreased. We've gone from almost 100 infants being dead per 1,000 live birth to less than 30 from the early 21st century to like the mid 2010s. And unfortunately, we've stagnated still since then, but we've come such a long way. And I think seeing the progress in real time during my career is what's kept me going. The other thing that has kept me committed to the work is how darn cute they are. I mean, it's hard to, as a pediatrician, our patients and our families are really tug at our heartstrings. So I'll let Colleen answer.
Yeah, I mean, I was very lucky to do my undergraduate training at Northwestern and get some education around global health and just understand like how big this world is, but like how much we're all just so connected. And that brought me so much joy very early on. And I remember my first project was looking at like sexual health in adolescents in Ghana and just having so much fun with it. And just realizing like kids and teenagers are kids and teenagers no matter where they are in the world. And I mean, they don't say like pediatrics is obviously a very joyful field no matter what discipline you're in. But I say pediatric global health is like probably one of the most joyful and rewarding fields to be involved in because kids are kids everywhere, whether they're sick, whether they're healthy, they're kids, and watch them get better is great.
Right. Well, thanks. I know the audience would love to kind of go a little bit deeper into this term that I think you guys use called bidirectionality. Uh, it's an important concept. I think folks who follow our work at the Global Health Institute have heard our message so much, and I think they get it. I think a lot of folks who don't understand global health still think it's us helping them, and clearly that doesn't work. We learned 20 years ago you can't drop in someplace, leave, and think that you'll have any sustainable effect. So the question to you guys is, tell us a moment when this kind of bidirectionality really kind of came to life, where you really appreciated this is a real partnership you guys have with these other centers.
I mean, I could just talk a little about from like the education standpoint. When I joined Lurie about 10 years ago, knowing that like it was intrinsic to the institution, I think was really incredibly eye-opening because it's not actually everywhere that bidirectionality is this like guiding principle. Um, and it's incredible the amount of work you can do when you exist as a partnership. So people are coming to you, you are going to them, you are sharing and kind of treating each other as equals as opposed to one group is the expert, one group is the recipient. And I would say, I've learned so much more about, diseases that I actually didn't see in training that maybe I'm seeing more now based on just having learned from my colleagues in other parts of the world and really bringing that home to my own institution. Similarly, like you can write grants with someone over WhatsApp and Zoom, and because you're bidirectional and kind of exist on this like equitable plane, it can be a true sharing of ideas as opposed to, one group imposing over the other. Sarah?
Yeah, I'd say as a physician scientist and researcher, there are, from an academic standpoint, questions that we're interested in that have really no impact on the ground. And so one of the biggest misconception really is that expertise moves in one direction and learning that and in reality, I've learned so much more from our partners as they've probably learned from me, but also kind of asking the right question, and there's a lot more effort to move towards implementation science, right? So how will things be implemented and kind of scaled up? And that can't happen unless you figure out what their needs truly are.
Perfect. Colleen, this one is to you. Those who've seen some of our videos over the years, I'll speak for myself. We've really enjoyed watching you in action at some of the partner sites like Tanzania and Kenya and Rwanda, where you've used your simulation to help prepare the local providers for a lot of high risk situations. Can you just kind of tell us what that training looks like, and maybe even tell us maybe a live example of how the simulation training prepared some of our partner sites for real crises that occurred in live patients?
Yeah, I mean, I think the cool thing about it is I mostly work with faculty when I do these trainings, so it's kind of showing faculty how this technique works, and it's really fun. It's really interactive. It's very you can't have a lot of ego or hierarchy when you do simulation-based education because you're all kind of in the trenches together. And it's been really cool. I'd say there's two main really interesting things that have come up. So one of the recent ones was our partner in Tanzania has been rapidly expanding their ability to take care of critically ill children. They used to not have ventilators, so any kid who needed respiratory support unfortunately didn't have any access to that. And they're having some of the residents were having issues trying to navigate different things, and there wasn't a ton of local expertise to help them learn from. So what we were able to do is just like on the fly develop a couple simulation scenarios of what could go wrong when a child was on a ventilator, and I've never seen so many more engaged residents who like had their phones out recording some of the casework and kind of furiously taking notes on different ways to help better take care of their kids. Similarly, we kind of trained the local pediatric faculty on SIM, and I got a WhatsApp video from them about a week ago where they said, they had a critically ill child with sepsis on the wards, and then they then ran a simulation on sepsis for their learners to help kind of reinforce some of the learning from that patient they had taken care of. So that was like real-time feedback that the technology is working and the training is working and it's being used.
Great. Well, those are great examples. I'm old enough personally to have lived through the era before there were simulation labs. It's a great advance in medical training. And when Colleen mentioned that they do this for pilots flying planes, I think if you've ever taken a flight, you're like, boy, I'm glad those pilots were trained. I grew up in the era that we half jokingly but half realistically called the see one, do one, teach one era, where we would watch a procedure, we would say, well, I guess I could do that, and then we would teach someone else, and they'd have to watch one and do one. And we learned, through 120-hour weeks and everything that my generation went through. But clearly, if we had these technologies of simulation, we would have been much more confident, much safer. It would have been scaled better. So it's a great advance, and it might look like it's just a dummy mannequin on the table, but the learning you can get out of that is amazing. And it takes these great champions like Colleen and Sarah to kind of bring that to these partner sites, and now you've really enabled them to scale up training their own folks. So it's really something that is a ripple effect that helps everyone. I'm going to give this one question to Sarah, and I'm putting you on the spot here, but because I'm sure you have many, but is there one story you can share with all of us today that really captures why this work matters to you and why it matters to the world, why we do it?
Yeah, I think so one of the kid that I showed in the picture, and this is why I keep him in the pictures. We went as a team and diagnosed him with HIV when he was around 10. It was very cachectic, malnourished. Didn't have a lot of options for treatment at the time, for which he became resistant. So I kind of passed the baton and left the country, right? Sometimes that's the hard thing. But kept in touch. And when I had the opportunity to go back to Malawi, he's now 20, has a family of his own with children who are HIV negative, right? And is now in chronic care because has developed complications from HIV, but is doing well and thriving. And I think it's a full circle moment because for me, my research really focuses now on how to keep people who have been born with certain infections healthy as they're, growing and becoming adults. So it really has been a full circle moment and kind of I don't want to say a pat on the back, but it's always great when you see that your efforts have been rewarded and that this child who's no longer a child is actually an adult is doing well and that his children are all HIV negative.
Right. Well, that's a great story. And again, for the audience, we don't think a lot about HIV in this country anymore. We take it for granted that people like the basketball player Magic Johnson, who 20 years ago came down with HIV, nobody thinks about it. He's alive, he's productive, he's wealthy, he does all sorts of things as a regular human being, but he is still exposed to the risks of growing older with this chronic infection. He is not cured, nor are millions and millions of people around the world. So studying what happens, the interesting thing about HIV and chronic care and aging is that we're learning lessons about the aging process in non-HIV patients just by taking this population of people that are aging a little faster because of that virus. So it's an example of science for the sake of science. We're learning a lot of lessons in both the pediatric and adult population by really studying that. So a lot of our adult docs in our Global Health Institute focus on the same research as Sarah. And there's just so many benefits when you just dig into any disease, infection, population that the whole world benefits ultimately. So it's just great work.
Add that we have this snapshot, right? Because he's 20 and my patients are still really young. And at a time when things can still be reversible. and interventions can really matter. And then I'll also add that, I also have a clinic here. I'm in clinic at Lurie Children's, and two of my patients today are 16 and newly diagnosed with HIV in the last month. So it
Yeah,
hasn't gone away.
it has not gone away. We all know, especially, from where those of us at the Institute sit, that this work can really be slow, and that the change that we do successfully have happens over years. It never happens overnight. So for the two of you, what keeps you energized? What keeps you hopeful? You're in a really long game. This is something you'll be in for decades to come, and you've got to have some dark moments where you're like, hey, am I ever gonna make an impact on problems affecting billions of people? And I get that same thought myself, and this is my 20th year of this. It's, what keeps you going?
Colleen, you want to tackle?
Yeah, I mean, I think just seeing what care looks like on the ground in other countries and being able to, like, to Sarah's quote earlier of how child mortality has just dropped in the last several decades. I think we really take that for granted. And I had this really cool experience. I was teaching at a new pediatric brain spasm fellowship in Dar es Salaam this year, and I was sitting at the nursing station. I look up, and this gentleman is like, "Hey, Colleen," and I was like, Teofil. And this gentleman who used to be a resident in Mwanza several years ago, who did an observership at Lurie, spent a ton of time with our cardiologist, really advancing his echo skills. We wrote him a letter of recommendation so he then could do a pediatric cardiology fellowship in South Africa, because there's not one in Tanzania right now. He was now the consulting pediatric cardiologist in Dar es Salaam. And that was just the craziest thing that, we had some role in his development of, small role of kind of getting him to be the second of two pediatric cardiologists in the whole country. So that's been really cool, is to see just in one country how things have changed with this partnership, and it makes it worth it.
Yeah, I will say the most hopeful part is seeing, as Colleen said, local leaders emerge and thrive, and really drive efforts within their community and the work forward themselves. As you say, progress is not immediate, but seeing change, and, improvement in infant mortality, almost elimination of maternal to child transmission of HIV in some countries, at a time when even in the 90s in the US, right, that was the number one killer, was HIV and AIDS. So when I look back, even for Colleen and myself, 5 to 10 years, and see how much capacity has been built and how many professionals have been trained and how systems have improved, it's incredibly motivating. It's slow, but you sometimes have to take that back seat and realize that actually through bidirectionality, we can see improvements.
And just to add on to that, the things that were death sentences 5 years ago, 10 years ago for children and aren't today, that's in our lifetime, that's just so crazy. Especially congenital heart disease was a death sentence for every child in the hospital we treat. Intestinal malformations, death sentence for 100% of kids who had them. Where in the US, 95% of kids survived. And just over, 5 years, for those mortalities to half. And it's insane, how this work actually does pay off.
Yeah, and one additional thing, though, we could talk about this for a while, is vaccines, right? So many children died of rotavirus, and now we have a vaccine. So many women die of cervical cancer, and now a lot of the work that's being done through the Institute is HPV vaccination. So it's incredible what baseline science and vaccination policies can do for survival.
So to your point, you've seen amazing stuff in just 10 years, which is crazy given that these problems have existed for hundreds of years, and yet in 10 we've really made an impact. Can either of you kind of get really kind of realistically forecast where you think your center will be 10 years from now, where you would like it to be 10 years from now?
I think one of my visions is to really, I think we have a fantastic center of global primary care, which I think is really taking that on. So I think what our niche can actually be, and this is one of my pipe dreams, is really connecting all those different pediatric specialties and expertise to partners who are doing the work in low middle income countries, because most children don't ever receive specialty care or even get care from pediatricians internationally. And I think by really leveraging Lurie and Northwestern's expertise, we can help those kids who have diseases that are survivable that hadn't been previously really thrive. So not just cardiology, not just emergency medicine, not just infectious disease, bringing our colleagues from pulmonology, nephrology, neurosurgery, critical care, and really helping build expertise. I think that can be our vision.
Yeah, I think in 5 years, a stronger network of what we're doing across countries. But in 10 years, it would be great for, our goal is not to be indispensable. And so if that means that local leaders can generate their own innovations and the programs that we've built can now be led entirely by local leaders, that means we can focus elsewhere and continue to grow. So it's to help build systems and leaders that they can continue to thrive independently and that we can tackle other places that may need us.
You can't live in a bubble in places like the U.S. with media everywhere, and we are seeing crises that spring up around the world, particularly in areas of conflict and in war zones. I always remind folks who ask me about what we do at the Institute that as much as we would love to be involved with boots on the ground in every conflict zone, in every crisis, in every Ebola outbreak, in every war zone, we don't have people to do that. And we are not Doctors Without Borders. They are a wonderful organization that serve that do a lot of good. We go at this from a different perspective in terms of training the locals, capacity building, and so forth. But a lot of folks still would love to hear the things you can do when a crisis comes up, when there is a war zone or a policy in a country that's a barrier from us actually going there. And I know there's some things you can do virtually in some of those areas. Can Sarah or Colleen kind of mention how you address those acute areas that need some pediatric global health expertise?
But probably one of the most difficult challenges of doing global health is that the world is there's always conflicts. For me, I've worked in Uganda long enough that I'm now on my third Ebola outbreak in the last 5 years. And so in these settings, and we're seeing this in the Congo, is that partnerships and trust and long-term partnerships are really essential to not only addressing whatever conflict, outbreak is ongoing, but continuing. If you've already created a partnership where you have worked alongside the local providers and community and health workers and NGOs for a long time, it's much easier to maintain access to essential services. So I'll give you my example of the Ebola outbreak now. I feel like our job is trying to keep the doors open and to maintain essential services for everybody. And so if that means that, our NIH grants is supporting a lot of that, if we can support the team to ensure that we maintain access to essential services, then that's what we're going to do. And even when resources are limited, trying to ensure that we preserve things like vaccination programs, nutrition support, maternal child health services, emergency care, which our programs don't do directly, because as you say, we're not an NGO and we're not Doctors Without Borders, but we serve as a role as an advocate, and using our voices and the infrastructure that we've built can not only highlight the needs of children, but also ensure that essential services can continue.
Yeah, I think even our Tanzanian partner, who we've been really close with for 20 years, there was quite a bit of political unrest last fall in Tanzania, and at this point we still actually can't have trainees go, and their trainees can't come to the US. But we've just fully flexed over to WhatsApp, and about once a month we do Echo Ed teaching sessions on WhatsApp where the Tanzanian residents are able to share different things that they've seen and have questions answered by our specialists here at Lurie. So because again, to Sarah's point of these incredibly long-term relationships, it was a no questions asked flex of just, we're not doing it in person, we're going to do it on WhatsApp, we're going to keep doing it because we trust each other and are there. And interestingly, one of my first endeavors to teaching simulation happened in 2020, and the grant I received to teach it, I think I got in 2019. And our plan was to launch in March of 2020, and it was to be teaching in Kenya, and we just quickly flexed to Zoom. And, I did a year of teaching over Zoom, and then the pediatricians there were able to teach all of their 50 graduating medical students how to resuscitate a baby born in extremis. And that was all done virtually. So it's,
Yep, another great example of
yeah.
technology.
Yeah,
Technology is going to help drive a lot of this. Uh, we can't have a session like this without waving our purple flag a little bit and letting the audience know, Northwestern in particular, there are global health organizations all over the country. We've been very successful at our growth over 20 years and how many centers we have and how much we're impacting. But you guys live this and you know the pediatric community nationally. What sets us apart from other universities doing global pediatric health work?
I think one of the coolest things about being housed in Northwestern is just how deep Northwestern's global health commitment is and how deep its commitment to education is. I got my undergraduate at Northwestern and benefited from global health education and helped found the Center for Pediatrics, 20 something years later. I think that's just the depth of global health at Northwestern, I think is really sets it apart. You have undergraduate, graduate, faculty training. You have centers that have all different expertise. There's really something in global health kind of for everyone here. And there's really, really, really strong institutional commitment to helping people be successful who want to do global health. And I know other colleagues who haven't had access to that. And I know I've personally benefited from just the deep kind of commitment the institution has to global health.
Yeah, I'll say having come from a different institution 3 years ago now, it's incredible the buy-in of Northwestern in global health, the world-class expertise that we have, just that the institute itself, the strong academic environment and genuine long-term partnerships have been incredible. I mean, we've been a center for about a year now, and we've been able to accomplish so much because again, coming together, Northwestern and Lurie, we've been able to leverage the incredible infrastructure that was already existent. So,
And then final question, since we're down to the last couple of minutes, is we all know that the work we do is really driven almost completely by the amazing philanthropic support we get from all of the people that support the institute in general. I can never have one of these webinars without a pitch for endowment. So I always bring that up. It's a big lift. We need $10 million to endow a center, but imagine a center like the Center for Global Pediatrics, if it were endowed with the $10 million and we could have spin-off money from that, imagine what your center could do. So maybe you can share with the audience, because I know there's someone listening right now that has their pen over their checkbook about to put that 10 number down. And so before they write that, tell them what philanthropic support's already allowed you to do and what could you do with future funding and especially with endowment. You've got 1 minute each.
I think we just support the people to do the work and kind of help facilitate from an education standpoint. We could be doing these simulation training programs in multiple different countries and then having these grants available to our partners to do their own like pilot projects that they want to do. I think that's what's been really cool about donor funding so far is it's supported really creative and innovative pilot work that's grown into these incredible programs, simulation being one of them. So I think that would be my vision from a sim standpoint is our reach gets bigger, our network gets bigger. We're able to have more Northwestern faculty share their expertise. We're able to have more international faculty share their expertise, and then we can support innovative projects on the ground.
Hey, Sarah?
yeah, I think philanthropic support always gives us flexibility to do things that traditional funding can't. So for me, I'm mostly NIH funded, but I've had pilot programs funded through the Institute that allowed me to do the MRI project, for example, and really think about how to be innovative, think about AI, train healthcare professionals on the ground, develop educational resources, which you can't do with just the NIH funding, right? And so for me, future investment allows us to expand what we already have, also grow to different countries. Colleen and I are talking about how to bring her simulation training to Uganda. But as you mentioned in your opening statement, we only have so much bandwidth. We only have so much support, right? And so doing this on our own time, having additional people to help us do this. And ultimately, our goal is to reach more children with higher quality care. So that's what philanthropy would allow us to do.
Great. Thanks, both of you, so much. And on behalf of the whole Institute, I am grateful to your work, to you guys for your work, to your center. Super grateful to the audience for listening to us. I know it's a nice day out and you've taken time to listen, and very grateful for your support. So I'll let Jen wrap this up. But again, thank you for all for attending.
Thank you for your time.
Thank you.
Jen?
Thank you so much, Dr. Fant, Dr. Fargo, and Dr. Havey for speaking with us. If any of our attendees are interested in learning more about the Havey Institute for Global Health or supporting our work,